Welcome to today's final main stage session. With NIC's mission focused on enhancing access and choice for older adults, one of NIC's 5 focus areas within our current strategic plan is partnering with health, which addresses the role that both senior housing and skilled nursing play in the health care of older adults. This session evaluates the strategies behind the alliances being forged between hospital and skilled nursing providers and the criteria considered. The panel will examine the expected outcomes of these alliances and the implications for the skilled nursing industry. Moderating this afternoon's discussion is Joe Kiernan. He is Chief Strategy Officer, Senior Vice President, Network Development with Ocean Healthcare. And Joe also has served many years on our Spring Conference Program Committee, who curate all of our sessions. So thank you for your leadership, Joe. And thank you to the panel. Thank you. Turn it over to you.
Thank you, Chuck. Well, welcome everybody, and thank you so much for joining our session today. We hope you're enjoying the conference and getting a lot of benefit out of it. We put a lot of work into curtailing the information and the topics, and hope you're again enjoying what NIC has to offer. It's truly second to none. So again, as Chuck said, my name is Joe Kiernan. I'm the Chief Strategy Officer and Senior VP for Ocean Healthcare. We are a mid-sized regional post-acute provider, mostly concentrated within the state of New Jersey. But before I get into what it is that we have to offer and a little bit more about us and me, I'd like to introduce and have them actually introduce themselves, but I'd like to introduce my amazing panel that we have here today. This is a smaller panel than what we usually have, so it's going to be a much more relaxed, comfortable conversation. It's going to be really a dialogue and a conversation together about what it is to actually forge those relationships for skilled nursing success as we move forward into the future. So it gives me great pleasure to introduce and have her introduce herself, Dr. Johanny Garcia, as well as Danielle Salazar. So Dr. Garcia, will you tell us a little bit about yourself and what you do at Robert Wood Johnson Barnabas Health?
Sure. Thank you so much for first having us. This is such an exciting conference. I am a conference junkie, and I have to say this one is very well thought out and well planned. My name is Johanny, and I am a primary care physician, and I have been practicing medicine, actually, I had to do the math, for 26 years. I was lucky to train in New York City, which was my home. I now live in New Jersey, at New York Presbyterian Hospital on the Columbia campus, where I trained medical students and residents and really focused on health disparities and working in underserved minority populations. After 17 years at Columbia, I left and was seeking the suburban dream in New Jersey and joined the VA as their Deputy Associate Chief of Staff, and really learned there my passion actually for change management across large health systems. I am now the Vice President of Population Health at RWJ Barnabas Health, where I partner with folks like Joe and others in the community looking to provide the best care for our patients at every encounter, at every one of our sites. And it's really rewarding and fun work. I want to introduce one of my colleagues. Danielle, want to tell them a little bit about you?
Sure. Good afternoon, everyone. My name is Danielle Salazar, and I am the Director of the Post-Acute Network for RWJ Barnabas Health. I'm a nurse by training. I've spent my 20-year career, the majority of the time in the post-acute space as a director of nursing, staff nurse. I've done kind of every job you could do as a nurse at a skilled nursing facility. And then I also worked for 5 years for a convener company, Remedy Partners, which is now Signify Health. I worked there for 5 years prior to coming to RWJ Barnabas Health. So in my role, I oversee our post-acute relationships with our skilled nursing facility providers, acute rehab, LTAC, assisted living, and home care. So every level of care post-acute hospitalization. And I also oversee our CJR program, so our Comprehensive Joint Replacement Program for the health system, which we have at 11 of our 12 hospitals.
Wonderful. Danielle, Dr. Garcia, thank you so much. And again, thank you so much for being on our panel today. We really do appreciate it. So I said that today's session is going to be a little bit more comfortable, a little bit more, I want to say relaxed. And the reason that is because we are actually partners in this venture together. So what I brought to the table or brought to the stage today is the largest health system in the state of New Jersey. And as a post-acute provider within the state, I am actually in their high performance network. So not only as your moderator today, I will also be representing the post-acute segment of our industry, representing hopefully all of you and what your interests are as I ask some challenging questions and some really exciting questions about what we do and how to best partner for our success as well as what hospitals are looking for with their post-acute partners. So a little bit more about me. I actually ironically started my life in healthcare at the age of 14 as a volunteer. And then working as a transporter at the age of 16, actually in what is now an RWJ Barnabas hospital. So it was a few blocks away from my house, and I started there, and I've never left healthcare since, entering the skilled nursing and post-acute environment in 1997, I believe it was, and have never left since. So I've had this wonderful, amazing career and experience and working with hospitals, having worked in hospital, truly understanding what it's like to care for someone, as well as understanding the business side of what it is that we do. So I'm excited to be able to step on both sides of that equation and work with amazing people like this on a daily basis. So as the program described, we're going to be talking about what health systems are doing and how they position, how we as skilled nursing operators need to position ourselves in order to really look at the future of how we work with acute care hospitals. So what I'd like to do is kind of before we get started is because this is a real relationship, there's not a lot of conjecture here. There's not a lot of theory or concept. What we're going to talk about is real, actual programming, real, actual life experiences that we face on a day-to-day basis in managing this acute and post-acute patient population. So what you're going to hear today will be actual real examples of what this network looks like, what it feels like, and how each of us has to position ourselves to collaborate and work together. So I'm excited about that part of it because I think we all oftentimes go to conferences and you sit there and either you get one little nugget out of an entire conference that you can take back to work the next week to your team, and that works great. And then oftentimes you sit in these conferences and you're like, this is just all theory and nobody said anything of real value. So we hope today that you get some real value that you can bring back to work when you go back on Friday or Monday or whenever you're leaving Dallas, Texas. So let's get started. Before we, I think it's important to take a look at where we're going. So as we move into 2024, we're faced with a lot of challenges and opportunities to maximize our positioning as post-acute and skilled nursing providers and really partner and look at how we can interact with our hospital and acute care health systems and referral sources. There's a lot of different components to that with changes happening on the and from a regulatory perspective and governmental interactions, such as the potential pending mandatory BPCI participation coming out, what I believe is in 2026, which is still on the table as to whether that's true or not, but that's what we're looking at as potentially one of the things that's going to happen. So we have to take a look into the future of what we're doing, but I think before we do that, we have to look at really where we were. So before we move forward, let's kind of take a step back. Previous NIC conferences and sessions talked about how do you engage with a hospital? How do you engage in a network? What is a network and how do I access them? So that's sort of the 101, the network collaboration 101 course. And if you haven't figured that out already, I think we're already a little late to the game. So today's session, we're going to be talking more at that 2.0 level. We're going to be going to the next level and really raising the bar on how we've already done the work. We've already done the homework. We've stepped in. We know who our hospital partners are. We understand what the networks look like. Now today we're going to talk about how do we really maximize the opportunities and the benefits of being in those networks and engage with our hospital partners to truly understand what we can do to maximize our outcomes and our opportunities. So with that being said, let's kind of dive into this a little bit. So one of the things that we had looked at in the past were how do we identify what a network alliance looks like? Oftentimes we didn't really know what that looked like, and how do we put that together? Learn what hospital-based referral sources are planning in light of changing, again, governmental opportunities and requirements such as shared savings programs like BPCI, accountable care organizations. Determining who to contact within that network. So before I used to sit down and I was actually quoted in an article one time of saying it's about data, not donuts. And it took a couple of years to figure that out when someone like Dr. Garcia and Danielle were in a meeting, and I'm like, okay, you're not the director of social work, and who wanted to just eat the bagels and the donuts that I brought. They're like, yeah, I've had breakfast already. What's your readmission rate? So when I didn't know the answer to that, I figured out that it wasn't about data, or it wasn't about donuts or bagels anymore. It was about that data, and I needed to come to the table with so much more. But that was, again, years ago. We figured that one out. Figured it out pretty well, actually. So, and we'll get into that. How do you get into the network? Who do you ask? Who do you talk to? It was undefined. I think the hospitals even didn't know at that point what they wanted to do, what they needed to accomplish. They knew they needed to accomplish something, but they were unaware as to what they needed to accomplish and how to do it. And where should they position themselves? So today we're going to define what we've evaluated to be really where the national acute care health system industry has positioned themselves with engaging, and how are they moving forward from a post-acute perspective. Today we're going to be discussing the options that hospitals and health systems have in front of them. Should they acquire? Should they merge? Or should they create partnerships? We'll define the options of the post-acute industry as taken to examine how to move forward. And again, on both sides of this dynamic, we'll take into account what the acute care hospitals and the post-acute care providers have from their perspective. So, as we move forward with our discussion today, we're going to, again, talk at a more of an advanced level. And what I'd like to do is go into how the hospitals have determined their path to move forward. So again, that's kind of enough from me. Now I'm going to ask some questions, and we're going to talk to our panel. So Dr. Garcia and Danielle, this question is kind of for both of you. Based on everything that we know and following national and local trends, how would you set the tone of our discussion today based on which is the most prominent of the choices that hospitals had to choose? And again, looking at partnership, acquisition, or mergers. So Dr. Garcia, you want to start us off?
Sure. I think we don't have our system slide up anymore, but I think we all can agree to say that healthcare is just really complex. You know, when I started training in 1998, there were a handful of hypertension medications, and now there are multiple new classes and dozens. So just to look at our system is just like the patients we take care of is really complex. It's very large. Not only in the services we provide, we're actually 12 hospitals across the state of New Jersey. Geographically, that is actually hard for people in New Jersey, maybe not in Texas, right? Because you guys have a lot of land out here. But healthcare is very complex, and we need specialists. We need expertise in all the areas that are required to give high quality care. And I think to answer your question, Joe, one of the things that healthcare systems realized is that we cannot just stand alone in a silo. We need to partner with community providers that have expertise beyond the walls of our hospitals, our medical group, you know, even our own providers. So when we look at, I think one of the terms that have been used in this conference, which I was very happy to hear, was whole person care. And really, in order to deliver that, we have to look for partnerships. Now, partnerships can mean many things. You mentioned mergers, acquisitions, joint ventures. Well, why don't we go that route? Well, we could go that route, but that would require really understanding where we're going when we're choosing that route. We need to understand that if we're going to take on an expertise that we may not have in-house, what is the investment needed to deliver that product to the best, the highest quality for that patient? And I think for our system, we took a look at ourselves and said, we know what we do well. We do heart transplants really well. We do pediatric care very well. We know quaternary medicine, and we have lots of partners that are within our walls. But some things we don't do as well, and that's when we decided on partnerships would be the best option, because that is where our financial model and our clinical care model really went. So I hope that answers your question, but it is a really good question that many of you may be facing when you're forming partnerships with healthcare systems.
Yeah. And your healthcare system has actually divested of a number of post-acute facilities.
Yes.
I know I purchased one of them,
Yes.
Along with also one of your assisted livings, and that was among others who other owner-operators in the state have acquired as well. So that decision, I think, has been made over time, and seems to be very consistent with what we've seen overall. So I think that, yes, you did answer the question perfectly, and it really gives us some good insight. And I truly believe that I'm not a big believer in staying in your lane, because I think you learn a lot when you get outside your lane, and maybe better outcomes come from that. However, practice your best medicine as a physician, and I think on the hospital side and the post-acute side, we've always said on our end that hospitals simply don't know what they're doing when they're post-acute.
I was going to say.
Danielle, can you speak to that? Because you've actually been on both sides of this equation.
Yeah. So I am not a health system kid. I was raised in a skilled nursing facility, as I like to tell everybody. So my career path was very different, and the first thing I noticed when I entered the health system 2 years ago is they have no clue what goes on in a skilled nursing facility. They don't understand the clinical capabilities. They don't understand the operating model. They don't understand the financial model. You say PDPM, and they're looking at you like, what are you talking about? We get paid by DRG. So I think as a health system, we're smart enough to understand that from operational and clinical perspective, we don't have the expertise within our system to manage nursing facilities. And I think a lot of health systems across the country are seeing that, and that's why they're starting to sell off those to skilled nursing facility operators who have that expertise and are able to deliver the quality of care to those patients. So I think as we continue over the next year, we'll see that relationship and those partnerships will strengthen, because the health systems don't have the knowledge to run skilled nursing facilities and be owners and operators of them.
Yeah. It's as we all know, it is incredibly challenging.
Yeah.
And I don't know that I'd want to do what you do either, but it's my job to also understand what you do, and vice versa.
Yeah.
I think that's really where our success in working together has come from.
Absolutely.
Yeah. So we do have the slide of your health system up and available. I don't know if we can put that up on the big screen behind us, but let me go back to one. There we go. So maybe would one of you just kind of take us through this so that the audience can get a good measure of what the RWJ Barnabas system looks like. So when we're talking about the scope and the scale and the scalability of the networks and how to work within those, I think it's important to understand the size and scope. So I don't know whoever wants to grab on
Well, I can
that.
start.
Yep.
You can chime in, Danielle. I think I mentioned it earlier, but we do have an extremely large system. And actually, we recently merged our system with Rutgers Health, and that's our new name now, is RWJ Barnabas Health, which is an amazing opportunity, because not only are we the largest healthcare provider in the state, but we are also the largest academic healthcare provider. So not only are we blessed with amazing staff and really top-notch clinicians, but we're also very involved in research and as well as education. We have freestanding behavioral facilities, which we know are just a big gap in our healthcare system. You can read the little pictures here on your own, but at any given time, we may have thousands of emergency room admissions and discharges. And as we look across our health system, I think this is important to say now is, you're seeing this picture of who we are, but behind the scenes, we're also under lots of regulation. We're also under a lot of pressure because we are very visible. And actually, I'm very proud to say this. We also are the largest server for the underserved communities in New Jersey. And so when you think of cost and how do we provide that care, we have a fiduciary responsibility to provide not only the best care, but to invest for those people who can't afford the care. So partnering in this value-based environment is critical to our bottom line and to our mission. So I just wanted to sort of mention that early on, Joe, because I think it really sets the tone of why our partnership works.
Yep, absolutely. Perfect. That's great. So when we look at how you guys have kind of formed and developed your high performance network, and that term has a lot of different, there's preferred provider networks. But I like high performance network because I think it really puts the emphasis on the fact that you do have to be a high performer. It's not being preferred, which I think leans more towards popularity, leaning back towards the donuts and bagels, and probably other things that are more inappropriate. But definitely the high performance that you really have to be able to put your money where your mouth is and to put the patient care and the outcomes where they need to be in order to ensure that you are serving that population the best way, which is why we're all in business in the first place, but to ensure that we're also meeting the outcomes for our acute care partners and all of the stakeholders that are involved. So let's maybe just take a quick look at what that network looks like. And I think, Danielle, you were going to hit on what that high performance design looks like and what you took into account, how you put it together.
Sure. So my position was created at the health system about 2 years ago. And prior to that, our SNF utilization network was always managed by a convener. So having the system invest in that position was them investing in the importance of those relationships and understanding the importance of our skilled nursing facility network. So currently, with our 12 acute care hospitals, our high performance network spans the 8 counties that those hospitals sit in. So it's broken down by county. There are 84 skilled nursing facilities. Now, those of you that are operators are probably like, that's a big network. It's a big network because we serve almost 3 million patients a year, and we discharge about 13% of those patients to skilled nursing facilities. So we need to be able to have the bed availability across the 8 counties to be able to discharge those patients to our high performance network. And then we have it broken down into 3 categories. So the top category is our highest performers. They have the highest quality rating, lowest length of stay, lowest readmission rate, strong partnership engagement. So all of those metrics are looked at. The next category is the performance network. So those are our facilities that have great engagement, but their metrics need some improvement. So whether it be their star rating or their length of stay or readmissions, they kind of sit in the middle of the pack. And then the last one is the additional facilities. And these are the facilities that take our most challenging patients. And because of that, their metrics look a little different. So coming from the post-acute space, the most important thing you have to understand when you're creating a high-performance network is you need to have a facility that is able to serve all patients, all payers. So it is wonderful that everyone wants the Medicare patients. Believe me, I completely understand. But I have patients that are behavioral health patients or patients that have vent needs or dialysis. And you need to be able to meet the need for every patient with one network. So when I create the network and when we did this network design, that's one of the things that we took into consideration. And so we work with these facilities that have kind of those more challenging metrics, and we have that partnership partnership and that collaboration to set up pathways and workflows to help improve those metrics. One of the things that I am most proud of is that I have a team of post-acute care coordinators. They worked with our skilled nursing facilities, and from 2022 to 2023, in a 1-year period, they reduced the skilled nursing facility readmission rate for our ACO patients by 6%. So that's a huge number, and that is to all of the work, not just for my team, but from the skilled nursing facility partners. We can't, my job is not to tell them how to run and operate their business. My job is to partner with them to make sure that I'm giving them the transparency and the collaboration to be able to give great care to our patients. So when we hand those patients off, we need to check all of those boxes. So when we create the network and when we reevaluate it on an annual basis, those are all things that we have to take into consideration, and we do put a lot of thought and effort into the design of our network, and we call it a high-performing network for that reason. We stopped using the term preferred provider network a little over 2 years ago, because preferred gives a negative connotation that you're not giving a patient choice. And we like for our patients to have an educated choice so that they can choose the best provider for their specific care. So that's why we use the term high performance network.
That's great. And I think on the post-acute side, we all really respect that and really look at how we can raise the bar for ourselves to step up to that definition and really become a high performer. And to be able to say, I'm a member of the high performance network at RWJ Barnabas, that should mean something, and it does. So we're very proud of it. For those of you, I didn't really get into it, out of our 12 skilled nursing facilities, 6 of my buildings do business, significant amount of business with the RWJ Barnabas network. They are my largest referral source in the state and the largest referrer for those, the particular 50% of my skilled nursing network. 3 of which of those buildings are the highest receiving buildings from 3 of their hospitals. So I have a lot of skin in the game relative to my performance and our performance to be able to not only stay in that network and be a high performer, because the outcomes are important, but my census is at significant risk. So high risk, high reward, and that is the life that I have to live on a regular basis, which I probably wake up at 3 o'clock in the morning every day. But, so I have a couple follow-up questions. So you have 84 skilled nursing facilities within the network. And you guys were not prepared for this question, but I'm going to ask it anyway. So how do you think that feels from a scalability perspective? Is that too large or too small? And I know that's a kind of a loaded question, but what works? Or let me rephrase it: what works better, a narrowed network or a broader network? And if you had your choice, which would you prefer?
Yeah, I'm going to answer that question, but I just want to go back a little bit to the word performance. I think that is a better term because it really aligns with our values, our values of measuring quality and data. So I just wanted to mention that really also was one of the reasons we chose that term. But in terms of the size, that's such an important piece of conversation, because as a provider, I'm always talking about, are we right-sized? And it really has to do with how many aligned partners are there in the community. So, and Danielle will chime in, but we would like to have as many aligned partners as we can, because we really feel that there are very strong partners in our community. I think the question is, are we all going to meet the standards that we all agree are the criteria to be in that network? And lastly, we do have to look at the needs of our patients. So, we're very data driven. We're looking at what is our length of stay, what are we seeing on our floors, what's the feedback from our patients, and if that really drives our decisions about what is the right fit. So it's a dynamic size, I think, which really goes to say that we tailor the needs of our population. So, it depends, I think,
Yes.
is the right question. It depends in terms of what the right size is.
Yeah, and I would say the size depends on your goals. Okay, so if your metrics are, if you're looking at your metrics and your KPIs, and one of your KPIs is your network utilization, which is for our case management team would want more, right? Because then they have more options and they're able to meet their KPI of performance network utilization. If you're looking to drive volume to specific providers to have better quality care, you may want a little bit more of a tight network. We have actually decreased our network. We decreased it by 12 facilities because when we looked at a volume and a geographic perspective, those 12 facilities were outside our catchment area and they were receiving less than 30 patients a year. So for them to put in the work to be an aligned partner with us, it wasn't there. So the 84 is a good size. All of our partners are engaged. The volume is spread, and it's really based on the county. So Ocean County, where we have 2 hospitals, we have 20 partners. In Essex County, where we have 3 hospitals, we have 23 partners. And in Middlesex County, where we have 1 hospital, we have 8. So when you break down the network and look at the county specific, you'll see that the way that the network was designed was to meet the needs of those patients, and we utilize that network more frequently. So it then does the return for the case management team on that network utilization. And really working with the case management team around understanding why those partners were selected. I'm not sure in the past they ever understood what the process was. So I spent a lot of time with all of the case management teams. I attend the directors meeting every month and really discuss and gain and ask for their feedback so that we can ensure that the network is going to be properly relayed to the patients and that they're able to accept, and make an educated choice. And then we're then going to get that KPI of network utilization.
Okay, that's great. So as one of those high-performing members, and for our audience, and I'm kind of jumping to almost the end of our presentation here today is with the question, but I'm going to follow up with it in a different way, is as a post-acute provider, I am excited to be in that network for a number of different reasons. One, I really am proud of the fact that we earned our way in, that we belong there. And so I got a seat at the table and I'm doing everything I possibly can to stay there. But give our audience a sense of where should they find the value? Why? Because we need to focus on our occupancy. We've given up length of stay because value-based care is pushing us in that direction. We've focused in on reducing those readmission rates, which is just the right thing. That patient, if they don't need to be in the hospital and they can receive the right level of care in our skilled nursing buildings, they should. So where is the value to a post-acute owner-operator in pushing their way and fighting to get into a high performance network like this, and what are you offering to them in a scaled up or scaled down version of that network?
Okay. Yeah. I think I wanted to just use our partnership, Joe, as an example. Yeah. So we are learning organizations, and through partnership, we actually learn from each other. And innovate together. So if I can, one of our pilot projects is working to increase palliative care, access to palliative care in the community for our patients who are being discharged from the hospital. So in a way, the opportunity for your organization is really diversification. We have a quality issue. Our patients are getting palliative care services in the hospital, perhaps not deciding on whether or not their loved one is ready for an end-of-life conversation like hospice, if that's appropriate. They need that conversation to continue. You were not in the business of that, of doing that kind of work. And because you recognized our need and our quality, that opportunity actually came up. Right. And so I think that is one of the value propositions of a true partnership, that you're learning together, right? And you understand each other's perspective. And I think we can also say that we're sharing resources and successes.
Right. And I'm sorry to interrupt you, but one of the things the audience is not aware of, just like because I didn't go into what my company looks like. So Ocean Healthcare, not only do we have our 12 skilled nursing facilities, we own and operate 4 hospices in 4 states, one in particular in New Jersey, hospice and palliative care, and we are the largest hospice in the state of New Jersey. And so when Dr. Garcia and Danielle and their colleague, Dr. Shira Budin, came to us and talked to us about this need to be able to connect their internal palliative care program to an external one, which they did not have. It was a great way for us to, as we said, lean in and step up and look for that. So my relationship became much more than just how many admissions I'm bringing into my post-acute facilities from the hospitals. It expanded into our hospice business. It expanded actually, and if you don't mind, I'd like to jump over to Danielle to tell a brief story about how it also jumped in from your behavioral health to not so much my behavioral health, because we too have 2 acute psychiatric hospitals and 3 outpatient partial care programs, but it was more on our behavioral health units, not behavioral health, but our memory care and dementia units within our skilled nursing, and one in particular where we made a significant impact. So that was something, maybe tell the story of that, and that was that engagement that you spoke about earlier, when you talk to your partners in the high performance network, why they are there is because of the way that people step up. So maybe talk about that.
Absolutely. So one of the largest challenges that we've seen in the last 2 years is dementia patients that are, as their disease progresses, they become aggressive, and then they end up with a behavioral health stay, and they can't return back to their nursing home because, it's resident-to-resident abuse, and it becomes an issue where these patients are sitting in the hospital for months on end, and they don't belong at an acute care hospital. They really need to be in a memory care unit that is able to meet their needs and help to control those behaviors by meeting those needs. So it was kind of my soapbox, and every quarterly meeting I had with my skilled nursing facility partners, their owners, anytime any of them would call me, I would use that 5 minutes to say, I really need help with these dementia patients. Like, we're struggling, and it's not fair to the patient. At the end of the day, this is not the right level of care for them. And so I would say, a lot of them had closed their dementia units during COVID. And I said, is there any way we could, you could think to reopen this or, certify your staff? And so Joe and his team at Ocean Healthcare stepped up to the plate, and they created, they have their memory care unit, and they had all of their staff certified. They had them dementia certified. And we joined the partnership of them with our behavioral health hospital, and we were able to place patients in that unit. And Joe, you can tell the story from your side. But I was happy because at this point, this is a solution I was looking for a 1-year period of time. And so for Ocean to come to me and tell me that they were ready at this point and that they had all this done, they actually invited me to the graduation of their employees from their dementia certification program. I was very happy to attend. And the thing that made me the happiest is our patients are doing well there. When I visit the facility and make rounds on that unit, our patients are really excelling, and the behaviors are controlled because they're in the right space and they're receiving the right care. So that to me was kind of one of the biggest successes of our partnership as a health system with a skilled nursing facility partner.
And it snowballed from there because you asking for that support or for looking at the network to say, here's a problem that we have, who is willing to try to fix this. So when we evaluated it, we looked at it, and I did not want to run or operate a behavioral health unit.
Correct.
It's not what we do. We have our behavioral health hospitals. They're very good at that, but that was not how we wanted to have our skilled nursing centers and our post-acute centers kind of configured. But when we really were able to dive down into it, we were able to figure out that these were memory care dementia patients with behavioral disturbances. That was a temporary issue for that patient. Mm-hmm. What we needed to do was get past ourselves and the fact that we saw one-on-one or Haldol or Ativan on the referral and just immediately said, no, this is a behavioral patient. We really dove into it and realized that we could, with the additional training and support and education for our staff, we were able to actually be able to take these patients. And from the skilled nursing operator perspective, I had 17 open beds on my memory care unit. That was far, far too many open beds. The unit is full because of this collaboration and because we stepped up. And then what we did, it turned into a whole company-wide program for us. So we were able to we branded the unit and the program as Encore. And we are now taking that company-wide. And so we're expanding that to all of our centers that have a secure memory care unit. And I still can I can still treat them as memory care patients, but really expand the amount of referrals that I'm actually considering for admission, and ones that are very appropriate for us to actually take care of.
Yeah,
Wonderful.
and the patients are in the right place, and they're not sitting on an acute care medical floor.
Exactly. And
Where they're being given Haldol.
And we're not bouncing them back and forth, and I'm just not sending them out to crisis. Correct. Who's going to just stabilize the patient, send them back in 6 hours, and and now I'm back in the same cycle. So, so again, that's one example of how to engage and re-engage your hospital partners, is to sit down, one, listen, but also sit down, and if they're not telling you what their problems are, ask them. I highly, highly recommend it. I don't ever go in and directly say, Danielle, do you have any referrals for me?
Or call and say, what's the census at the hospital? Because, I have like a whole unit open over here, so send me all the referrals.
And she does get those phone calls from other people. She's not getting them from me or our team. What I say is, what else do you have going on? We need a new project. Well, we've got enough going on right now together, but what else can we do? What else, where's the length of stay issue? Where's the readmission issue? What diagnosis can we go after? I'm interested in developing a stroke program. What kind of stroke discharges are you looking at? What's your highest number of discharges? And look at the geography. Which center should we focus? Let's pick one hospital, one center, and let's focus on that.
Yeah, and aligning our goals, for our system, heart failure is a big initiative for 2024. So in the last quarter of last year, I started having those conversations with our skilled nursing facilities about, when they would say to me, okay, what's coming down the pike for 2024, like what should we focus on? I said to them, heart failure is gonna be our largest focus, and we need to reduce our heart failure readmissions. So having, heart failure programs at your facilities, having cardiologists, and really knowing how to manage those heart failure patients so that they don't readmit will help us to align our goals. It keeps the patient in your bed and out of the hospital. So it's really about goal alignment and conversations, and that's how the strategic partnerships work.
Exactly, yeah. So we took a little bit of a detour there, which I thought was a good one, because we gave some real, again, we talked about this being a real life a panel and not just conjecture and theory. So we need to get back to what this looks like and feels like. So I'd like to ask the two of you to talk about what you took into consideration when choosing who is in the network. What components did you take into consideration to say, this is a facility or an organization that should be part of us? What defines high performance? So I think we have a scorecard here. So Dr. Garcia, we talked, and you mentioned this once before, but I'm going to ask you to speak to the quality component of this. We've broken this down into 3 core aspects, but I really would like to hear, because and they all kind of go together, because I don't think you can have quality along with data, along with engagement, and they all have to kind of align.
Yeah, I mean, they all drive each other.
They really do, and there's a cause and effect to each of them, but maybe just speak to quality for us.
Sure. So quality really is where we start the conversation. We want to give our patients the opportunity to make an informed choice, and informed with data that those patients can understand. Patients who are in the hospital, families are looking to their providers to give them some idea of what does quality mean. Although I am a big proponent that patients, as soon as they walk into a healthcare facility, they know what quality is. They don't have to be physicians. They're consumers of healthcare. They know what quality is. So that is really the most important, the first conversation. And I have to also say that as a learning organization, and I think Danielle touched upon this, we want to support our partners. If you're our partner, we want to support your growth around all the criteria that we use that sort of got you into the high performance network. It's not like when I went to college and I was sitting in my chemistry class and the professor said, look to your left, look to your right, the people next to you probably won't be here.
Right.
You know, so it's not like that. So it really is about learning how to manage your data so that you can measure performance continuously. Not once a year, not just when Medicare comes by. No, it has to be a continuous process. And when we see that perhaps you're not achieving the goals that you yourself, our mutual goals, that we're able to step in and say to you, hey, you're not, you know, something's wrong, you're veering off the path, how can we help you? Because our success really is your success. Mm-hmm. We're in it for the patient. And so as we keep that North Star, quality drives our values and aligns us. So that really is the first of the conversation.
And I think, just jumping off of something you said, I think it's important for our skilled nursing audience to understand. One of the things that I learned a long time ago was we used to just not want to air our dirty laundry. It was just hide the deficiencies, hide whatever was going on inside. Don't tell anybody about it. You didn't take the admission because you didn't have a bed, not that you didn't have enough staffing, because now no, they're not going to send you anybody. What I found out was pull all of that aside, pull back the curtain, call them and say, I need your help. Mm-hmm. And that's going to go to one of our other conversations, which is engagement, and I'm jumping ahead again. But it makes a very big difference when you do, and especially when you're talking about quality, because you have a level of expertise that that definitely we don't, and we need to learn from that. But you also, and then from that, it really pulls back the curtain and allows you to see how that works in our environment, which again, two completely separate dynamics.
Well, it's about patient safety.
Yeah.
Right? One thing I learned as a physician is the first thing I do with patients is I tell them what I don't know. And so I think, that it's all about that. It's all about being transparent with our partners and our patients and seeking to improve. Mm-hmm. Right? I think that's really important.
Yeah.
Yeah.
And
so,
sorry, Joe.
Yeah.
For just that collaboration, that partnership, we do have very real conversations. I have the facilities call me and say, listen, Danielle, I just want to let you know I'm sending Mr. So-and-so out to the ER. This is what happened. And I'm really sorry. The case manager is going to be upset, but I can't accept them back, and this is why. And so together, we work on where are we going to find placement for this patient. And I just had the situation last week. I was away in New Orleans, and I received a phone call, and they said, Danielle, the patient's in the ER at Trinitas. This is what happened. We've tried to manage this patient up to this point, and we've sent the referral to this place, and this place. The last thing we really wanted to do was send them to the ER. But today, she got out of hand. She punched a staff member, then she hit another resident. Okay, you clearly cannot handle them in that setting. I said, okay, let's do this. I said, these are the 4 facilities that have SCNF units. I said, have your social worker send the referral. I personally know the owners of the SCNF. I'm going to call them and ask them to evaluate the patient and see if we can move the patient from the ER straight to the SCNF so that they don't have to come back to your facility, because at this point, we've determined you cannot care for the patient at that level of care in a skilled nursing facility. So those are the type of things that we work through. And years ago, the health systems, the relationship or the vision as someone coming from the post-acute world was, oh, well, the hospital thinks because they send us patients that we have to do everything they say. And so they'll just say, well, you have no choice, you have to take it back because, we send you referrals, right? Mm-hmm. And the relationship has definitely changed to where health systems and skilled nursing facility partners really have a collaboration on these cases. And they work together to work through those hard patients. So I think that's one of the benefits of these partnerships, that help both sides. And at the center of it is always the patient.
Yeah. So because we started going down this road with the collaboration, so I'm going to jump the data portion of this and ask you to continue that conversation.
Sure.
With regard to engagement and collaboration. It's not just, again, sitting at the table. It's what are you doing? Like, are you just sitting there? Mm-hmm. And those phone calls. The phone call to say we're sending a patient out. Here's our problem. So talk about how provider engagement and collaboration comes into your decision-making process, because quality, obviously, like you, Dr. Garcia, you said, the quality has to be there. So you're going to have certain metrics that you are going to set in place to say, you have to be here. That's maybe the price of admission or the on-off switch. Now we're going to talk about then your data, which keeps you there. Maybe you might not be there right away, but can you get there? But the engagement part. So maybe talk a little bit about that.
So I think that is just really, really critical. I'm not sure like which one is more important, right? But to me, engagement really means accountability. I think that we as a hospital system are accountable to our patients and our partners, and also to be engaged with us. The skilled nursing facilities have to also be accountable to our values and our mutual goals. So we really look for partners that can come to the table with that approach and can have honest conversations with us. It's not a popularity contest. It's about, the care of our patients, and are you meeting the goals that we have set? For example, we all live in this value-based care world now. Of course, the work that we do in our team in population health really crosses our entire book of business, from hospital to outpatient. And our partners have to understand that, there are some things that we may not be in alignment of, right? Because my length of stay, might affect you in a negative way when I want to bring that down, or vice versa. But we have to be respectful of that. We have to be respectful of the other partner's perspective. So for you, the volume coming in from a more narrowed performance network is really important. And I have to be cognizant of that, or we have to be cognizant of that. So I really feel that is what, when I think of engagement, when I go to the partners, it's a two-way street. It's really about accountability to each other. And I just wanted to say one thing, which I'm looking at Danielle, and I'm seeing the resources that engagement entails. Not only do you get somebody like Danielle coming to your facility, but you also get an entire team from our RWJBH staff, nurses, that are going to now be embedded in your facility to help those patients, to partner with those patients. So I think that's what we're talking about.
Definitely, and from an engagement perspective, I meet with my team every Friday morning, and we review all of the patients that are in the facility for more than 20 days for our ACO patients, and we also review any communication challenges. So we had a facility who has been at the top of our network in one county for 7 years, since the network was essentially created. A year ago, their administrator, who had been there for 25 years, retired, and a new person came in. I cannot get this man on the phone. I cannot get his team to answer our emails. They are the highest volume out of my one urban hospital. We literally filled their building, and I cannot get them to answer an email or a phone call. Wow. So in the evaluation of the network, that is one of the crucial points, because I need them to work with me. The volume's there. I only have 4 facilities in that county that I'm working with. They have to answer the phone. So navigating those challenges and working with my team and teaching them how to navigate those challenges as the person who is the main contact for that facility is one of the things that we work on the most, because engagement really is extremely important. Quality is always number 1, but engagement is number 2. Because if you're not an engaged partner, you can get on the network, but you're not going to stay there if you can't answer my phone call.
Yeah, and if that's a significant component to what brings you into a network and what pushes you out of one, I have a feeling that if that facility, I'm not sure which one it is, but if that center is now no longer going to be part of that network, I have a feeling you're going to get that phone call.
Yes.
Yeah,
sure. Absolutely.
Yeah, for sure.
It's always like, wait a minute, I got this letter, because I send letters. When I remove someone from the network, I send a letter via FedEx. And it's funny, because the person who hasn't answered the phone for a year will call me and say, oh, Danielle, I got your letter. And I'm like, okay, but you didn't get my phone call or my email. Right. So it's a very interesting position to be in.
But I just have to say one thing, Joe. I think we take that process of reviewing our network very seriously. There are some formal structures in place for our network. There are agreements that we sign so that we're all like cognizant of what we're getting into. And we do have criteria that our partners know about that we review on a yearly basis. And actually Danielle and I just went through this not too long ago. And it's not something we do lightly. And there's a lot of conversation even when the data is there to support removal of somebody from the network. And I just have to say also that our leadership, our senior leadership, is in alignment with this. So if you are thinking of joining a partnership like this, the work, like you mentioned, Joe, of going to the network, the health system, the hospital, whoever it is, and really sitting down with that senior leadership and making sure that your whys, I think that was also a term that was used in one of the sessions today, are in alignment.
Yeah. So let's talk about data really quickly because we're running short on time, and I want to give the audience some time for some questions. So what we call key indicators or performance data, we did have our scorecard up. I know that we'll speak to some of that. So Danielle, can you just give us a quick snapshot of what that looks like and which components of it you use?
Yeah, so the scorecard that it was up on the screen is a scorecard that we use out of a technology solution that we invested in at the beginning of last year. It's called Point Click Care Pack Network Management. And what this tool does is it allows me and the skilled nursing facility to see the data for their patients for our ACO and Medicare lives. So in the past, this process was very cumbersome and it would take hours of pulling spreadsheets and creating slides and then going to each facility and giving them their specific, and then I had to download the Excel spreadsheet of the patients. So this platform allows me to see my entire network, and then it allows me to see an individual facility. So the individual scorecard that's up, obviously I've blinded it for my skilled nursing facility's privacy, but this facility is a high performance. So they're the top of the list for Essex County, and they, as you can see, their length of stay and their readmission rate are both under 20%. So when we look at metrics, we're looking at the length of stay, the readmission rate, the volume of patients, and then I always include acuity because the data for a vent HD patient is going to look very different than facilities that do not take patients that have that high acuity. So you really have to gauge the CMI of the facility and know that when you're looking at the data. But this scorecard allows the facility to see how they're doing with our patients and which patients go into the data that they're looking at. And it's the same view, so you can log in any day of the week and see your data. And so that's one of the other things that being a Performance Network partner has brought is we've invested in this solution, which is free for our skilled nursing facility partners to be able to see this scorecard.
Because otherwise, I would have to think very quickly on my feet and do quite the tap dance when I walk into the conference room and you hand me my performance. And I have no idea what that is until I get in there without investing in my own data analytics programming so I can dive into the same data that you are, but even then, there was always a disparity. It was which population are we looking at? So is it just the RWJ or is it my overall performance? Is it just your ACO population or the total population coming in from the hospitals? So we were always apples and oranges and it never kind of matched up because you would say I was at 22%, I said I was at 18%, and I'm like, which one is real? And so this has been a great thing and quite groundbreaking also. I think you really did set a precedent as a health system, and I know, Danielle, this was a massive initiative of yours to partner with one of the largest skilled nursing EMR companies and create that partnership where that is a real value proposition and truly one of the benefits of being in the high performance network with the RWJ Barnabas network. So I'm gonna ask you guys both a question, and then we're gonna open up to the audience if anybody has any questions. But I'd like to ask you both the same question. So as a post-acute provider, I have invested in my buildings to make sure that they are comfortable and beautiful and a place that people want to be. We've invested in our staffing. We've invested in our program development and clinical capabilities, educating our staff to ensure that we have all of the highest level of clinical capabilities possible to accept those patients. So given that we are all investing to try to do this, to try to capture those patients, what would your one piece of advice be to our audience and to a skilled nursing owner-operator of what they could do to get that business so that we can focus in on our occupancy, so that we have the revenue and the means to be able to reinvest in our communities and our properties and reinvest in the care that our residents and our patients deserve?
That's a hard question, Joe. I think it's really important for the skilled nursing facilities to understand their business, understand who they are, what they excel at, where are their opportunities for improvement, and really come into a conversation with, this is who I am, these are the things I can provide. So I think that transparency is extremely important. I think the second thing that you really need to understand is who your partners are. How many times have you've been at a meeting and the person across from you doesn't really know your business, doesn't understand your values. You may not even understand what your goals are for that year. So that seems very basic, and it's you're all thinking, of course we do that. But I think from a value proposition, you have to be transparent and say, okay, RWJ, I see that you have a problem with readmissions for this particular population. Maybe let's work on that. Yeah. So I think those are two very important things that have to be at the table.
Okay. Danielle, the 3-second answer.
That's okay.
No,
I echo what Dr. Garcia said.
Chuck will come get me when it's time.
Same thing. I was going to say, know your partners, get out there, talk to the health systems, find the right person to speak to at the health system. It's often not the social worker you're bringing cookies to. Many of the health systems across the country now have positions like mine and are very sophisticated around their post-acute network. So find out who that person is and meet that person, whether it's via Zoom, you send them an email, and get in front of them and really find out what it is that they need and what you all can bring to the table for that partner. I would say find the right person at the health system is probably the best advice I could give you.
Yeah, excellent. Well, we did run out of time. Were there any questions from the audience? And if there were, we will stay around, and please feel free to come up to us and be able to ask us any questions directly. I do need to be respectful of the time for the conference and the next sessions taking place. I would really just like to say a very big thank you to my partners, my colleagues, and my friends. Dr. Garcia, Danielle, thank you so much. This was a really exciting discussion, one that we have all the time, but I would love doing it here in what I would call my second home, which is NIC. Truly, thank you so much for the value today. Thank you so
for
much.
the opportunity.
Yeah,
Thank you.
I would second that, Danielle, Johanny, and Joe. Thank you for keeping it real, providing the real-world examples of the high-performance network with aligned partners. We welcome your feedback. Please use the QR codes or the kiosks at the back of the room. We're now in a 30-minute break, which started a few minutes ago. But the last session today will be at 4 o'clock. It'll take place next door at the Innovation Lab. It's focused on accessing public funds to increase market appeal. Immediately following that session is our evening networking reception that starts immediately at 5. It will be out on the street along the side of the hotel. And then tomorrow morning sessions start at 8:30. The second session at 9:45 is our capital markets and economic update, which features Doug Duncan, the chief economist of Fannie Mae. So we hope you can join us tomorrow morning as well. Again, thank you to our panel. Really appreciate it.
Thank you.